Right, so we're now live on Zoom and Facebook, and everybody's had a chance to join, so we're going to start the webinar. Welcome, thank you everybody for attending. We've got over 200 people on, and thanks in particular to our panelists for joining us. We're going to be talking about navigating changes as shielding pauses. Obviously the situation is different depending on what leukemia or blood cancer type people have and what the situation is in different parts of the UK, but a lot of the issues remain the same. So we're joined by haematologists with expertise in different specialisms. I will say now they don't profess to be necessarily experts in COVID. I'm not sure many people are, but we can take the learnings from their clinical expertise. And we're also joined by Nick, who is himself a CLL patient and is going to talk from his perspective as well to give us that insight. So we'll take it in turns to introduce who we are, and then we're going to have some opening comments from everybody. So I don't know if Mhairi, you want to introduce yourself first for anyone who doesn't know you.
So hello everyone, I'm Mhairi Copeland. I'm a consultant haematologist from Glasgow, and I've got a specialist interest in chronic myeloid leukemia.
Thanks, Mhairi, and I realise I didn't introduce myself either. So I'm Zach Pemberton-Whiteley, and I'm the Patient Advocacy Director at Leukaemia Care. So Mary Frances, do you want to introduce yourself?
Hi, I'm Mary Frances McMullin. I'm a haematologist in Belfast in Northern Ireland. And my particular clinical interests are the treatment of patients with acute myeloid leukemia and myeloproliferative neoplasms across the spectrum. Thank you.
Thank you. And Chris, do you want to introduce yourself? You're on mute. Had to happen at some point.
Yes. Hello, I'm Chris Fegan. I'm a haematologist in Cardiff. I'm also R&D director, so I was intimately involved in a lot of the COVID trials and work that happened here in Cardiff.
Thank you. And Nick, do you want to introduce yourself?
Hi everybody, I'm Nick, a CLL patient, navigating shielding with you all and working with Zach at Leukaemia Care and the clinical community to keep us all informed.
Okay, thank you. So as I said, for those who joined us before, we're using the chat function here on Zoom as well as comments on Facebook. So if you have any questions as people are talking, post them in there throughout as people are talking, and then when everyone's had a chance to comment, we'll get to the Q&A and I'll be putting all of the probably really difficult questions to our panelists. So I think Chris is going to kick us off by sharing his opening thoughts.
Yeah, so afternoon everyone, thank you for phoning in. I've only been out of the hospital for 5 working days since January, and that's really COVID that's dominated everything I've had to do since it hit us. I just thought I'd give you a brief overview of a bit of the hospital experience, because I think it's pertinent to actually where we're trying to get to, because although at the time we thought dealing within the hospital with the pandemic was going to be difficult, I think we've now realised coming out of that lockdown, or everyone will call it, and getting back to a normal life is actually going to be more difficult than maybe we anticipated. We all took the message on board: stay safe, go home if you can, work from home, try not to go out. I think the whole UK did that really well. And if we're trying to come out of that new things are appearing, maybe we weren't thinking of back in March. So in the first week of March, I'm one of the assistant medical directors. I was dragged to a special meeting, and you're always worried about those. You're either going to be sacked, you're going to be disciplined, or you're going to come out with a job. And ironically, it was none of those. We were just told that in Cardiff, we expected the pandemic to hit Cardiff in the last week of May, and we all had to be prepared for maybe the disruption to the work that we normally do and to prepare for this. So give you an example, we all had to do retraining. People like myself who don't do a lot of acute care outside the haematology spectrum. I had 30 minutes of how to run an ITU, which I thought was quite good actually. I thought it took about 10 years to train a critical care doctor, but I did it in 30 minutes, which either I'm brilliant or they just realised I was a waste of space and don't waste any more time on him, get to other people. But in fact, it hit Cardiff on the 8th of April, was our biggest actual day of admissions. And we hit over 50 patients in a single day arriving in the hospital. So it was very rapidly, it was gloves off, and we just all had to stop doing what we're doing and all hands to the pump. Because at the time, as we went into the pandemic, there were no known treatments of benefit for patients. And I think it's fair to say a lot of the medical profession just had to learn as we went along. And I think we still are learning, and that's why. So some very reasonable questions we'll get today. It's still going to be a lot of opinions. And I say it started, we were told it would hit Cardiff the end of the May by the experts, Public Health England, Chief Medical Officers, same in Wales. So they got that wrong by about 7 weeks in reality, and it just hit us and we had to get on with it. We're now in the situation, though, that we know in the last week in Cardiff, there were only 7 positive patients in the whole of Cardiff. And they're not in hospital, that's in the community. It's almost effectively gone away. During that time, when the pandemic hit, having entered the pandemic with no treatments, for those who follow this, we learned that hydroxychloroquine, despite President Trump's assertions, is of no benefit. Certainly to people who enter hospital, it's of no benefit. We found that an antiviral called lopinavir was of no value. We found that dexamethasone was of great value for people requiring oxygen and those who were most ill. The UK played a leading role in all those discoveries, more than the world, and they put over 12,000 patients into the study. So a lot of everyone's efforts in every single hospital around the UK was actually putting patients into what was called the recovery study. So as we sit here now wondering what's going to happen, we will be much better prepared going forward with therapies. We know what works, we know what doesn't work. There's at least 20 other drugs being trialed in patients at the moment. So if it does come back, then we should have better treatments. We have learned an awful lot from the pandemic as we've gone through. There is no doubt, though, that the major thing that stopped things being even worse than they were was actually the lockdown. It was stopping people meeting other people. And we know from what we've seen that it can spread through households if you're all locked down. So being away from other people is the most important thing. And there's a recent report from the Centre for Disease Control from America that still says that person-to-person transmission through droplet spread, airways, is the major way that this virus actually spreads from one person to another. It can live on surfaces. It's thought it can survive on plastic about 3 days. It's thought it can survive on glass about 4 days, probably much shorter for paper and for clothing than that. And that means in simple terms, if you get the letters through the door and you just leave them on the floor for 4 days, you can open them knowing it's safe. Or you can open them at the time and then make sure you wash your hands well, having touched them. So we've learned an awful lot about the virus than we thought we knew at the beginning. But there's no doubt as we come out of lockdown, there's still the major way of spread is probably droplet spread, like any other respiratory disease. Hand washing is very important, but it's not the most important thing. It should be one measure along with others, which is why social distancing is just so important going forward. You'll have seen the news about mask wearing. Does it work? Doesn't it work? It certainly appears to protect people passing the virus on if they are carrying it. And we now know that maybe 30–40% of people who get infected are actually asymptomatic carriers. And we would have read the papers and seen the television programs. Once it got into hospital, was it then passed from patient to patient and then back out to the communities? People got discharged through asymptomatic carriers. We know it can happen. So in fact, we think the herd immunity is more than we can measure at the moment. We know in Cardiff, through antibody testing, maybe about 10% of people have been exposed to it. We know in hospital workers, from reports around the UK, some specialist groups, it's been over 40% of patients have got antibodies, sorry, not patients, staff, who've got antibodies to it, have clearly been exposed and recovered from it. A lot of them never knowing they ever had it. So the herd immunity is probably more than the 10% that we think of, because we now know that the antibodies don't appear to hang around for long. So there are other forms of immunity, notably T-cell immunity, that probably matters. But there are now about 160 vaccines being developed across the world. The Oxford vaccine you may have heard of is the #1 in terms we should know first about that, if that's of any benefit. That does appear on initial testing to look very promising. It shows that people can get an antibody response to it, and it's shown equally as important, your T cells can respond to it. So I think vaccines will be coming. We may need more than one. One nice thing about this virus, if there is a nice thing, it doesn't seem to mutate as much as maybe we thought it would. We know it does mutate because we know in Britain it mostly came from Italy, not from China. So it does mutate as it divides, but it doesn't appear to be mutating particularly rapidly. And when it does mutate, it doesn't appear to mutate in a way that would make you worry that the vaccines may not work. One of the good things about having so many vaccines in development, they're targeting the virus in different ways. The Oxford is doing it in 2 ways, but the Imperial vaccine is doing it a completely different way, and there's other innumerable vaccines. So if the first one doesn't work, there will be others come along. And we hope to hear about Oxford, maybe by the end of this year. They're trialing it now in Brazil, which is the country with the second highest incidence in the world, and they're doing it in America. So ironically, Britain may not benefit from the vaccine directly, but we will learn in what's been a global pandemic. And it shows what a small world we live in now, the way it's spread, but the way the information comes out. The Chinese sequenced the gene and released that to the world very, very quickly. So I'm very optimistic going forward that we will have vaccines available. Britain has already ordered from 3 separate companies vaccines, and we have deep enough pockets. I know we're broke as a country, but we're still wealthy compared to many, many others. We still have deep enough pockets to buy more vaccines should we need them. So as we come out of this, we have to be very careful. It's still social distance. It's still washing hands. I think face masks make a lot of sense. I still think we should only go out with a purpose. That purpose may be exercise, avoid people. I've actually eaten out 3 times in 2 weeks, having not eaten out for 5 months. I've felt very, very safe. The places are taking very seriously people's safety. And so I think as we come out in growing confidence and the news comes through of vaccines and other treatments being developed around the world, if it does surge, it's likely to be a local surge in cities and towns rather than across the UK. And with steps being taken, we're monitoring lay people in the community in Cardiff and other parts of Britain. We're actually working our way through the sewers, seeing how much virus is being excreted into the sewers in Cardiff. They'll find more than COVID down there. I'm absolutely certain about that. But that sort of monitoring is going on. So we're going to go into this, the unlockdown period, with a lot more information we ever had before, which is why I think we can take our tentative steps out of this with a lot more confidence than we ever had going into it in April, when we all were a bit blind and completely unaware of what was coming our way. I specialise in CLL patients we know are more prone to infections than other patients. We know they don't respond as well to vaccines, which is why we need that herd immunity by having a good vaccine for the population. But a lot of my CLL patients locally in Cardiff are going out. They're trying to get on with their lives. They're going back to work. We know from data we acquired a lot of patients with CLL will recover from the virus should they get it. But of course, the best thing is obviously not to get it in the first place if you can absolutely avoid it.
Okay, thanks, Chris. Thanks for the overview at the start. I will hand over to Mhairi to have some comments at the beginning.
So my specialist area is chronic myeloid leukemia, which is actually one of the conditions where the risk from the virus isn't increased as compared to the general population. So within the UK, so far as we know, we've been trying to collect the numbers of patients with CML that have contracted the virus. So there have been, I think, 8 patients so far reported in the UK with CML who have developed COVID-19. All have recovered. Across the world, as of yesterday, there were 159 cases reported of CML patients having COVID, and almost all of those had recovered. So the advice for patients with CML is to follow the national guidance regarding social distancing, the wearing of masks, etc. And the specific risk for a patient with CML is dependent on their age as well as their comorbidities. It's not a function of the CML, and it's not a function of the treatment for the CML.
Okay, thank you very much, Mhairi, and I'll hand over to Mary Francis as well.
Hello, that was a lovely talk, Chris. I'd make a few comments about Northern Ireland, and overall, we've really been very lucky. As you stated, we had the disruption to the service in prospect for the wave that was coming to hit us. Interestingly, we were being told it was somewhere either side of Easter in mid-April, but it never quite arrived. Thankfully, the numbers, there were certainly significant numbers of patients, but it was at quite a low level. The problem about it all, though, was the preparation and the disruption to the service for this, where our patients don't know where they're coming when they come in because we're somewhere different. So there is a whole issue around that. But thankfully in Northern Ireland now, we're now down at very low numbers, but it hasn't gone away. Somebody just down the corridor for me has just been sent home because somebody in their kid's bubble has tested positive. So this is going to be an ongoing issue. I think what's very important is the things we've said. Luckily in Northern Ireland, we've had very good contact tracing from the beginning, and we now actually have an app which is for the whole of Ireland, up and working in the whole of Ireland and talking to each other. So that will be interesting to see. But I'm going to make the same points. It's all about social distancing, hand washing, the wearing of masks. And I think it's quite interesting because the social distancing came in first, even before the shutdown. And I just wonder how much was that a feature in keeping the lid on this. Obviously, London was hit first, and that wasn't there in place. Everybody's got back to work. All the workplaces have been made COVID safe. And there's been huge amounts of work. You made the point about the hairdressers, the restaurants, all of that. The other point I'd make is great amount of work has gone into making the hospitals safe. We are up and have all our clinics running, some people by telephone, but some people coming in to get their bloods, but there's a one-way system. There's all the greens area. So we would very much encourage people that the hospitals have been made very safe. As regards my particular areas, which are very diverse, acute myeloid leukemia, well, it's no different from it's always been. Patients who have treatment for acute myeloid leukemia are extremely immune suppressed for a few weeks. That's why we have them in hospital until they're in remission, and again with further chemotherapy. But once they're in remission, have recovered their blood counts, these people are actually immunocompetent. And there will become a point where they're really pretty good from the point of view of infection. Myeloproliferative neoplasms, of course, that's a complete minefield because it goes from everything from people with end-stage myelofibrosis on a lot of therapy to people who take an aspirin, and that every so often. And this is what's been a difficulty with the shielding, because they all got put into the same advice that they should shield. And it's a very different thing from somebody who's on various medications and very immune suppressed to those who basically come every few months and get their blood counts monitored. But thankfully, shielding is now paused, hopefully good long pause, permanent. And come back to what do people do now? It's very much obey the rules that we all have to obey: shielding, hand wash, or social distancing, hand washing, the wearing of masks. Thank you.
Thank you
Can
very
I
much.
just add back in, Zach? So from the CLL point of view, we've done a survey of hospital doctors of CLL patients being admitted, As of this morning, there were 58 CLL patients admitted to hospitals so far through the COVID pandemic. We think there's about 20,000 CLL patients in the UK. So that's 0.25% of CLL patients actually ended up in hospital. We've done a bit of work on those patients and looked like half of them were never shielded. For whatever reason, they'd decide they didn't need to or they couldn't. So in fact, if you were shielded, your risk was something like 1 in 1,000 of actually coming into hospital with a COVID infection. So really very low in reality. But I think that is about those preventative measures, because we know the CLL fraternity did lock down extremely well indeed.
Thanks, Chris. And I'll pass over to Nick as well to share some comments from a patient perspective.
Thanks, Zach. And Chris and Mary Frances are married, really informative and alluding summaries. From a patient's perspective, I've actually just been using this as an opportunity while listening to reflect back to when COVID first started to come over the mountain, and and when we knew it was coming. And at that time, I was reflecting as a person living with, knowing I was immune compromised, that in the winter seasons, I automatically follow an element of social distancing and personal hygiene. I hear somebody sneeze at the other end of a train carriage. I was always very wary of traveling in public and confined spaces. And I remember writing a blog at the very beginning. Maybe we can use this as an opportunity to help the rest of the population that aren't used to living like this. This is an area of strength that maybe the majority of us as patients already have. And I think then shielding happened, and that was all thrown away, because we didn't need any of it, because we were safe in our little bubbles. And so the challenge, as Chris was alluding to earlier there now, is we're no longer able to hide. We're no longer able to be made safe by everybody. But what we can do is lean back on the strengths that we may already have. Now, of course, there are going to be many in the audience who haven't been diagnosed for a long period of time or may not be used to living in an immune compromised position. But I think we could almost look at it, and I've kind of treated it, just to throw it in the mix, it's been a little bit like a re-diagnosis again. When I was diagnosed, I really went off the deep end with fear and worry about how immune compromised I was. And when I heard about the propensity of potentially catching the flu and what it might do to me, it was very hard to balance that, to be able to live life. And after a while, that became a new normal for me. I remember when I first reached out to a charity, I was given broad advice, even though nobody knew what my immune challenge was follow these particular hygiene regimens. And, you will find out with time your own risks. Well, obviously with COVID, we can't find out, what our risks are, but we can remain vigilant, keep an eye on our community. So we're informed on the prevalence of the disease potentially, and maybe lean towards our strengths and part of the way is look for confidence, how to build that confidence. But there are grey areas. I mean, I'll be honest, I'm not going to be going out into where there are groups of people unless I have to. I'll make particular missions with purpose and stick very strictly to social distancing and personal hygiene guidance. But there are grey areas that the community we're having a problem with challenging. I can voice myself, relationships. I sit there, I'm a bit of a loner anyway, and I don't spend a lot of time with a lot of people, but I'm finding it very hard to engage with others. And I'm thinking of, those in families, people with children going back to school, having to go back to work. I'm fortunate working with a charity that's very aware of the challenges, so I'm able to work from home shielding. So I'm hoping that we can have these discussions in a minute, and answer everybody's questions to look at some of the variables here, because it seems to be massively individual. Everybody needs to be able to operate safely within their own confidence boundaries and be as informed as possible. And from that point of view, I'm just going to start off by reinforcing the one thing is that if you're unsure about what you can and can't do and how safe you are, talk to one of your specialists, talk to your care team, talk to Mary Frances, talk to Chris, talk to Mary, because they can help give you, help strengthen your resolve to be able to move forward. So I think rather than giving a lecture, I just wanted to share some interesting perspectives there. But I think really what we've got a chance now is an opportunity as patients to use the skills we've all learned since diagnosis. We've now just got to employ them and just remain vigilant.
Thanks, Nick. I think that leads very nicely into the Q&A. We've had lots of questions coming in already. I'll start with one main topic, which is around shielding. We've had all kinds of different queries in relation to this, and I would say worries at both ends of the spectrum, perhaps. So those who, obviously shielding coming to an end, those who are wanting to continue shielding, and able to do so, and worried about whether that's the right thing to be doing. And then the other end of the spectrum, we've got people who are not shielding, who are being asked by employers perhaps to go back to work, or family members going back to work, and wondering what the risks are for them. So I think we'll, if possible, ask each of the clinical panelists to comment from their perspective and for their particular disease area. So I'll hand over to Mhairi first to give your comments for CML.
So for CML, certainly our guidance was that patients with CML shouldn't be shielding unless they had another health condition that meant that they needed to shield. So if they had diabetes or heart disease or lung disease alongside the CML, then those patients should be shielding. But actually having a diagnosis of chronic phase CML, provided it's controlled with a tyrosine kinase inhibitor, such as imatinib or nilotinib, then the actual risk to these patients was not above that of the general population. So our recommendation to our patients, and when we spoke to patients, was that our patients should observe the rules that the general public was following. They should wash their hands, they should wear masks, they should employ social distancing, but they didn't specifically need to shield unless they had another reason for shielding. And most CML patients were comfortable with that advice. Some patients were anxious, and for those patients, they did choose to shield, but most patients were comfortable to continue just to observe the social distancing measures and hygiene measures that the general population was observing.
Thank you. And Mary Frances, in terms of both one end of the spectrum, perhaps AML, and then MPNs, maybe cover each in turn.
Okay, so in all areas, we basically followed what was given out by the government as those who should shield. And it was people with blood cancers such as leukemia and lymphoma at any stage of therapy. And I think this caused a huge problem. Who was sending out the letters? Who was getting the letters? Etc. And the trouble was, there was, as you said, this goes for AML and MPN. It was a spectrum from people who were very, very keen to shield to people who didn't really want this at all. The record I found was one patient who had been sent 7 letters telling him to shield. He was about 5 years post bone marrow transplant on, none of them were sent by me, 5 years post bone marrow transplant on no treatment. There was no reason he should have had a shielding letter, and yet 7 different authorities felt it within, I have his permission to quote this as well, that he had been sent a shielding letter. And that was the difficulty, but certainly for AML, people on treatment or within a year of treatment, it made sense. The myeloproliferative neoplasms, we said that patients on treatment should shield, but there's still a problem with that, with what actually is treatment. I think overall, we're glad that the shielding has paused, because you can now advise people to move on, but to be very careful to obey the things that the whole population has to obey, and practice social distancing, practice hand washing. I think is incredibly important. You go in somewhere, the first thing you do is wash your hands because you've been all over the place, and wearing masks.
Thanks. And Chris, from a CLL perspective? You're on mute again, sorry.
So CLL patients are more prone to infection with or without treatment. A lot of hematologic malignancies is the treatment that actually makes you more immunosuppressed. That's not correct with CLL. They're immunosuppressed anyway to varying degrees as patients. So all patients are more prone to infections, which what slightly sets them apart from other groups of patients. We know they don't respond as well to vaccines. We know they need more antibiotics than a lot of other patient groups. And we know it's a disease of the, sorry, Nick, the more mature. It's an old grey man's disease. Sorry, Nick, to stereotype you in that way, but
COVID hair.
I could have got a better actor than yourself. And you looked unkempt as well, but that's not part of the phenotype, that's just you. So we know that CLL patients have to be slightly more careful than others. But to put into context, in any given year with CLL across the UK, we expect between 700 and 1,000 deaths in patients with CLL. We know over the 4.5 months of the pandemic that we've registered 25 COVID deaths in the UK. There may be more, but those are the ones we know about that have been registered by British haematologists. Over that same period, there will be a lot more patients have died of CLL from other causes, vastly more than other. And of course, those patients, half of them didn't shield, so they were putting themselves at risk, but they were actually wandering around when the rate in Cardiff was 300 per 100,000 of the population, not like it's 3 per 100,000 now. It's 100th of the frequency it was at its peak. So the risk now is really very, very small, but it's not zero, which is why the hand washing, social distancing and being careful is still the most important thing out there than it was before. But there's two things when you talk about COVID deaths, and this came up with Public Health England. If we now know some patients can excrete the virus for 6-8 weeks afterwards, but it's not live virus. People are not contagious. It's probably cells being released from the surfaces inside the airways, which have got dead virus in, but you can still detect it. And so one of the problems about screening people, there's a lot of argument, can you catch it twice? Because you can find the virus twice, weeks apart. There's really, at the moment, no evidence you can catch it more than once. That doesn't mean you can't, but there's really no evidence out there that that happens with any regularity whatsoever. So for me, the pandemic, the thing that's made the CLL patients so safe is that social distancing. But now we've got the prevalence of it in the community about 100th of what it was. So of those patients who came into hospital who didn't manage to get out with it, that's not too different. It may in fact even be lower than we see on an average year anyway, where people are not taking care. They're still doing their general things, making them prone to heart attacks, strokes, road traffic accidents and other things. So it'll be very interesting. You'll have seen that excess death they're talking about across the UK. What was the actual excess death rate? For CLL, I don't suspect it'll be much different to what it was in a normal year in reality because of what people did. Because normally people do go round. They do go round and get flu. They do go round and get pneumonia anyway with normal daily living. They're surviving and they're living. So it'll be very interesting whether Leukemia Care and others can actually look at what was the excess death rate in AML, myeloma, myeloproliferative or CLL, because actually it may not be very different than what it was normally. That doesn't mean what we did was wrong. I think the shielding protection is absolutely right. But I think it's quite easy to get into a feeling that if you leave your house, all of a sudden your risk is enormous. Because I think actually, if you take the right precautions and you're very sensible, the risk at this moment is very low. If we get another surge, that's different. But at the moment, the risk is very low. In most of the country, there's a few towns and cities you need to be a bit more careful in, but we know where they are.
Thanks, Chris. So I've got some follow-up questions coming through on similar topics. So the first is, if people are going out in the community, some worries and concerns about this. So I'll share a few different examples, and then people can comment on those separately. So the first is around going out in the community and other people not following the social distancing, not following masks, and being worried about that. And then the second part of the question is around things that may or may not be safe to do so. So is it safe to be using public transport as a patient who had previously been shielding? Should you be going to shops, restaurants, or hairdressers? And again, we'll have different comments from the different experts in different disease areas. So Mhairi, do you want to go first again?
So for just thinking about CML patients specifically, obviously, as much as possible, you want everyone to adhere to the guidance of wearing masks. The mask protect other people more if you have the virus and cough or sneeze than provide you with protection from others, unless you're wearing one of the specialist FP3 masks. In terms of going to particular places, again, for going to the hairdressers or going to the shops or going to a restaurant, for patients with CML, they should observe the same social distancing measures as members of the public, so keeping 2 meters distant and making sure that you use these track and trace so that you're booked into restaurants and things, so they've got your details and they can contact you if there's a problem. Wearing a mask when you go to the hairdressers. In terms of public transport, again, book if you're taking the train. If it's a longer journey, you can book in advance. And I think it's necessary. I think everyone has to book in advance for the train so that they can put people, sort of space people out within the train. In terms of public transport, again, it's still relatively quiet, certainly in the areas where I've been. Public transport isn't being fully utilised yet. And a lot of people are still using their cars, but over time that will increase. But for CML patients, so long as you're maintaining the social distancing, it'd be really important when you get to your destination to wash your hands once you've been using public transport, but there's not a reason for you not to use public transport.
Thanks, Mhairi. Mary Francis for AML and then MPNs.
So I don't think I'm going to say anything different. I mean, it's the same message all the time. In all these areas, public transport, shops, hairdressers, etc. I mean, these places have all undergone very careful assessments, lots of screens in, trying to keep everybody safe. And they've all had sort of risk assessments for the COVID, to make them COVID safe. And our university at the moment, half of it isn't open because they still have to go through to make everywhere COVID safe. So I think this has all been very carefully thought about in these places before they're opened. And I would be reassuring to people to go. Obviously, there are places that you may not want to go. In Northern Ireland, you don't want to go to a karaoke party in Limavady. That was a big mistake, but you know, who's going to be going to that? It's the places where people that have been looked at and are very carefully followed. And I mean, it's not particularly an AML or an MPN issue, it's the same right across. I think the other question was about what do you do when people are not following the rules? And I think that is difficult. But I also do think people are quite hard on people. Where I live, there is a sort of back road where everybody went for their walks, and up at the top there was a place where some young people sat out in the open, well spread out in 2s or 3s, and you know, you thought fair play to them, the kids have to get out and they're well away from each other, but you can see everybody going past going tut 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 because more than 2 people are gathered together. So I do think people try to be careful. Same thing in our outpatients this morning. It's beautifully laid out. way apart, half the number of people in that there used to be, and people were saying to me, oh, it's very busy out there. Well, actually, they're all well apart. Nobody's sitting beside anybody. Everybody's wearing a mask. So I think we'd have to do that. But obviously, I think as time goes on, people do obey the rules more. When the masks came in a couple of weeks ago here, almost nobody was wearing them, but it is coming in more and more. So I think we just encourage people as much as possible.
Thanks. And then Chris, anything different to add from a CLL perspective?
Partly from a CLL. I mean, the problem is that it's a bit like driving your car. You may be a very safe driver, but the idiot rushing up behind you is not. And therefore, when you go out, you can only take the precautions you can take. And if a situation you feel is not safe or you're unnerved by it, then the simplest thing is to leave that situation. I have eaten out 3 times. I had to book a table. It was very sensibly done, dare I say. I had the table in the pub for an hour and a half with my son. He tried to do me for money. You know, he got his hour and a half say, but it felt safe, and I think it was very safe. Back to my own experience, you know, I run the R&D. I had 50 research nurses running around this hospital, going on the COVID wards, meeting the COVID patients. We had 3 members of staff actually get COVID. 2 of them were married to ear, nose and throat surgeons, who are the ones who got it and got it worse in hospital. We think they called it off them. The whole family's got it. And the partners got it before they did. So we're pretty certain they caught it home. And we had 1 who we don't know where they got it from. It may have been home, it may be work. I was meeting with these people for 3 hours a day, 3 hours a week, Monday morning, Wednesday morning, Friday morning for an hour, 8 till 9. We just did the social distancing. There's about 8 of us in the room. We could do the 6 feet social distancing without masks because we worried about the hospital run out of PPE. And to have a meeting, therefore, we're using all the masks when it's needed on the front line. That's how we started. So my own experience over 5 months of being in a hospital and literally 1 wall thickness away from patients ventilated, etc., is it was very safe. If you wash your hands as often as I did a day, I didn't wear a mask at all up to now, but you just kept that 6 feet rule. My staff who went into the COVID areas, they wore the proper PPE and they were very safe with it. We had 1 out of them, we're not sure where they got it from, but the other 2 almost certainly from their partners. So that's why I think social distancing really does work. As you go out, one thing people worry about is toilets. It's one thing to be in a pub or a restaurant. What are the toileting facilities like? Again, the places I went to, the first thing I did, my wife would say I do this all the time, is go straight to the loo. Yeah, make room for the drink. But part of the reason was to see what it was like. The toilet would tell you a lot about the hygiene standards of the place. If you go in the toilet and you don't look like what they've done, then that's probably telling you something about how seriously the management have taken the whole issue. But as I say, you will have those places, which I've been fortunate, very, very safe, and you have other places where they're spilling out of the pub onto the pavement. There is no social distancing, there is no mask, and you're back to behaviour that we thought may have left us for a while. But boys will be boys, I'm afraid, and I say girls will be girls. So my suggestion would be, is it's small steps, build up the confidence, but whenever you go into a place, it's almost a recce. If you go to the toilets, where are the hand gels? Have they segregated off the areas, etc., etc., etc.? That tells you how seriously the establishment is taking this. But they want to take it seriously, because if they get an outbreak that's linked to their place, their business, then they are closed down again. They are absolutely desperate to get it right. And that's been my experience of what they've done to date.
Thanks, Chris. Okay, so we've got, again, lots of different questions coming in, and I'm going to try and theme some of these. So the first one is in relation to children and school. So we've had some people worried about their children either going back to school, some people worried about themselves, our teachers, and whether social distancing in the classroom is a realistic prospect, whether children are going to be wearing masks and what they should be doing about it. So I won't pick on Mhairi again first, but maybe Mary Frances, do you want to kick us off on this one? You've just muted yourself.
Sorry. Schools. Well, first of all, I think that it is absolutely crucial that kids get back to school. It's an absolute disaster that children have been out of school for so long. And I think there's some horrific figure of 750,000 children who haven't had the access to online teaching and etc. etc. So getting the schools open for the future generation has to be extremely important. As regard, again, the schools are looking at this and looking at it. It's not going to be the same. I think it's not going to be 2 meters social distancing, but they're having bubbles, shared time, and looking at all of that. I think from the patient's point of view, it's difficult if the particular patient, I mean, there may be an issue if somebody is a teacher, certainly if it was an AML patient, you wouldn't be thinking of them going to work until they'd been well past their treatment, and that has to be considered. MPN, I would say differently, unless they're particularly falling into particularly immune compromised groups, which would be the ones with end-stage disease or ruxolitinib. Again, they may have a very good case to make not to go to work, but the other ones, it's back to all the hand washing, etc., and getting on with life.
Thanks. I mean, Chris or Mhairi, I don't know if you have a different opinion to add. Maybe Chris, I think you're itching to speak.
Not a different opinion. Can I just make a comment about the term immunocompromised? None of us have antibodies to this. Absolutely none of us have antibodies to the COVID-19 going into this pandemic. So the word immunocompromised, really what we're talking about, I'm just as likely to get it as an immunocompromised person, but I hope my body can mount an immune response to stop me getting it severely. So it's not that I'm less prone to get it, it's just if I do get it, I have a better chance of getting an immune response to it than people who are immunocompromised. And I think people confuse the two. One is the risk of getting it, and one is the risk of it actually making you ill. And that's why, Mhairi says, with CML patients, where they're not thought to be particularly immunocompromised, their risk is still the same as a CLL patient, but you would hope a CML patient will be able to mount a good immune response to it, like a relatively healthy person who's had no hematological problem at all. So it's the way your body reacts, which is the important point, as opposed to is my risk higher than anybody else's. We were all at risk of this, as we mentioned, because none of us have ever seen the virus before.
Thanks, Chris. I don't know, Mhairi, if you have anything you want to add to that.
I haven't really got anything new to add. I'd just say I think it's critical that our children get back to school. That's been approaching 6 months without any formal education. For CML patients, for those that are teachers, again, they have the same risk as Chris has just said of developing COVID-19, but you would hope that they will mount a good immune response and they are not at an increased risk of developing severe disease and being admitted to hospital, that they will have a similar course as somebody in the general population. For those people with CML who have other medical conditions such as diabetes, they maybe need to think more about whether or not they should be going back or finding out what precautions are in place for their place of work. But for somebody with chronic phase CML who's otherwise fit and well, they should feel confident about going back to work and that their risk is not significantly increased.
Thanks, Mhairi. So I think that leads quite nicely on to the next topic of questions, which is around working. So a lot of different questions coming in about people who are concerned about their workplace being COVID safe. So where does the balance lie between if you're able to work from home? Clearly that's a possibility for some patients, but if you're not, if your job is something that can't be done from home, what would you say? And that includes, again, teachers, that may include people who work in supermarkets and are customer facing. What would you say the risks are for those people going back to work? So Chris, I don't know if you want to go first.
Well, again, one of my memories of this pandemic will be those shop workers. My wife was shielding, she's immunocompromised, she's on long-term immunosuppressants. We couldn't get a shopping slot, so Muggins here had to go to Tesco's on a Wednesday evening and see it, and all those staff there at the beginning of the pandemic had no PPE at all. As it went on, Perspex shieldings arrived, because there's no doubt the more people you come into contact with, and I mean contact, the more chance you have of catching it if they happen to be a carrier and an asymptomatic carrier. So I think it's impossible to say that if you're doing a job such as a teacher and meeting a lot of pupils, some of whose personal habits leave something to be desired, then there is a chance, if it's going through their household, that you have a higher chance of catching it. Again, with children, if they keep the 2 meters away, then I think you're relatively safe. Wandering around the class, I definitely wouldn't do. I would stay well and truly behind my desk. I'd probably have a red line 6 feet around and say to the children, do not come near into my space. I would have the hand sanitizer with me all the time. And personally, I would think about wearing a mask. Even though the evidence isn't really there that actually it helps me or prevents me catching it off a child, what it does do, if you happen to get it on your hands, it stops you fiddling with your mouth. Because if you do get it by contact from a surface, it's from your hand into your mouth. And it's quite interesting with Zoom and everything. I've had two really great experiences. I now virtually know the IKEA catalogue. I've been in so many people's living rooms over the last 5-6 months. And I see what I want to buy, and I certainly see what I don't want to buy. And my opinion of some people has changed enormously because they got dreadful taste looking at their homes. But there's no doubt if you've got a mask on, you're less likely to fiddle with your mouth. And again, on Zoom, you see people doing things, touching themselves in their mouths. And before I never noticed it, and I probably did it myself. But you notice it if you shouldn't be doing it. So I think a mask, in a sense, gives you a bit of protection of actually, if you do touch a door handle or you do touch a surface that a child is touched, you're then actually putting it yourself. You can't absorb it through your skin. It's got to get in you through the airway or into your mouth. That's the only way to catch it. So sanitizer, personally mask, maybe gloves, and then you can take the gloves off and throw them away and then wash your hands still. So I'd probably take those precautions. I appreciate it's a teacher having a mask on at the front. May not be easy to actually teach a class like that. And kids can be cruel, as we know.
Mary Frances, do you have anything to add?
I think that's very good advice of Chris's. The other thing I would say, I think people need to take it on an individual basis what their particular job is and discuss it with their consultant, because there are so many subtleties in this. Certainly when the shielding letters were going out, we had many people came to us, and if they felt they had a particular problem and wanted to shield, we wrote letters for them. And I think it's the same with particular occupations and a particular patient's situation. They should be prepared to discuss it with and think if there is anything more that they need to do, or if they should be going back to work. And again, that's always been the case. I mean, we always had those conversations with people after bone marrow transplants and things like that, what their job was and when they could go back to it and should they go back to it.
Thanks, Mary Frances. And I should probably comment from a Leukemia Care perspective at this point that we have an advocacy and welfare team. So if you are advised by your particular consultant that it's not safe for your particular situation to go back to work, please do get in touch. I'll share details at the end, but it's advocacy@leukemiacare.org.uk, and we're trying to help people explain to their employers the risks and why they should be able to work from home, for example, if it's not safe for them to go back to their job. Obviously, the furlough scheme is continuing, and the furlough scheme continues to make it appropriate that if you are vulnerable, you can be furloughed on that basis if it's not safe to do so. That's not saying it's not safe, but if your clinician thinks it's not safe, you can continue to be furloughed. And if you need help communicating to your employer about that, please contact Leukemia Care. Mhairi, I don't know if you have anything to add from a CML specific perspective at this point.
I haven't really got anything specific to add. I mean, I think if people are concerned, they should discuss it with their consultant and come up with a personalised plan for each person about how they integrate back into work. I think that's really important if people have got other issues that may be contributing to their reason for shielding and their sort of worry about coming out of shielding.
Thanks very much. I'm conscious, Nick, I haven't given you a chance to comment on some of these questions, so I don't know if you want to share your perspective as a patient.
I think it was mirroring what everyone said and finishing off with what Mhairi said. Some people, I think it's grown-up decisions. There's some very, there are going to be some very difficult decisions that a few people are going to have to make to balance their feelings of their risk, and difficult conversations that you're going to have with employers and about looking at risk assessments. So having a third party like Leukemia Care, plus obviously being able to balance and understand that risk, getting the advice from your consultant is the best route to go. But I don't think we can shy away from the fact the situation isn't ideal, and people are going to have to make decisions that may impact on livelihood, when having to weigh up risks to health and being able to maintain an income to support the family and the household, and also putting children back to school, how that's going to impact on family associations and bringing risk. So the situation is not ideal. That's what I was going to say from that point. And use whatever skills you have, but I think from a patient point of view, it's not a situation where all of the questions can be answered.
Thanks, Nick. So conscious of the time, it's running away with us, and we're having so many different questions coming in. So I'm just going to share the screen again with where you can reach out to for further support. So just to say here, there are obviously a series of webinars. Now we're going to be continuing to do them as Leukemia Care. We've got lots of blogs around shielding and risks of staying safe on our website, information coming through newsletters to your inbox, magazines, social media, etc. So please do keep an eye on those. And if you have further questions, please reach out. Obviously speak to your healthcare teams for individual clinical advice, but if you have worries and concerns and are looking for support, please do reach out to us. Next slide. Variety of our normal services are continuing to run. I know a lot of people are quite worried at the moment. So Helpline, support groups, and the welfare and advocacy that I mentioned before are fully operational. We're running these as normal. So again, you can continue to access them. Obviously, COVID is not the only thing to be worried about. People may have clinical questions about their leukemia or general worries that they may want to talk about. This is the contact details of how to get in contact with Leukemia Care. They're all on our website, so anyone reach out to us in the normal way. And we're not the only charity. There are, of course, many other blood cancer charities who are providing similar advice, and we're working alongside many of those. So reach out if any of you aren't aware of these other charities. Please do reach out to them as well. So the last thing to say is just to thank everybody for joining, thank our panelists in particular, And as I said, if you have any questions, please do reach out to your medical teams. And if you want further support, reach out to Leukaemia Care or any of the other charities on the screen. Thank you very much. Take care. Please do follow the precautions.
Thank you. Bye.